much of what I will say, I think, will be a continuation of what Robert has already talked about. And that is the presence of a insufficiency of the tricuspid valve due to changes in the loading conditions of the right ventricle. And that's something in congenital heart disease we see with some frequency, mainly because the right ventricle plays a very different role in congenital heart disease than it does in the acquired. And often we have to address insufficiency under very different conditions than we would see in the adult. In the adult, the tricuspid regurgitation is usually addressed as a consequence of left-sided problems. Usually in the pediatric, we're seeing it as a primary problem. So this is obviously a very big topic. I'm going to divide it up into a couple of different areas. And the main reason is because at least in adult congenital heart disease, the role of the tricuspid valve in generating serious morbidity is actually quite important. We tend to think about it in certain lesions like Epsteins, and maybe in the older tetralogies after repair. But we also see it in Eisenmenger's, a very different type of problem. But then when the tricuspid valve is in the systemic position, such as in transposition that has had an atrial level repair, or in corrected transposition that's had a physiologic repair, the tricuspid valve is the left-sided AV valve in these patients. And so these kinds of lesions actually generate a tremendous amount of morbidity. And so you have to have a pretty good understanding of how you're going to manage them. The kinds of defects that we see, I think a lot of this has already been mentioned. For example, Professor Backuleva mentioned the acquired septal leaflet immobility from people sewing the VSD patch or in tetralogy or Fallot onto the septal leaflet. This is a very common problem. However, the solution is usually relatively simple, and that is closure of that commissure. Simply closing that commissure is enough in most of those cases. Epstein's I will talk about separately, very different disease which requires a complete reconstruction of the valve. And then the other component, which is the tethered leaflet. This is actually much more common than we think. I think it's an extension of how we should view functional tricuspid regurgitation, and I'll explain why in a minute. But perhaps some of the ideas and some of the concepts that we developed in congenital for tethered leaflets causing tricuspid regurgitation, I think have applicability in adult functional TR. And then obviously the systemic tricuspid valve in transposition with atrial repair or corrected transposition. So this is an example of a tricuspid valve that happens to be sitting here on this ventricle. This ventricle is a morphologic right ventricle, except it's on the left side. This is congenitally corrected transposition of the great arteries. So what you notice here is that there is a significant degree of tricuspid regurgitation, but more importantly, this leaflet, the septum is here. So this is the septal leaflet. The septal leaflet, rather than starting up at the annulus up here, it's actually starting down here. And that's the cause of this. We call this Epsteinoid deficiency, but it really is just tethered septal leaflet. And this is one of the major causes. So we can see in a tricuspid valve that's in the systemic position either this Epsteinoid tricuspid valve, which I'm showing an example, or just as equally frequent, we can see functional TR in those patients. And so the same approach of repair rather than replacement should be undertaken for these patients. And I'll put the repair concept together because I think, as I said, it follows very much along the lines of what Robert was talking about before. When I talk about tethered leaflets causing tricuspid regurgitation, I'm talking about this lesion. So this is the tricuspid valve. This is the septal leaflet. And if you notice, the septal leaflet is tethered on the edge, doesn't really move towards the middle. Often the anterior leaflet, which is here, is also tethered by this papillary muscle. But what happens is the resultant regurgitation jet is enormous. This patient has a very, very severe tricuspid regurgitation. But if you notice here, the annulus often is normal. So an annuloplasty ring here is completely ineffective. And in fact, for this lesion, these kinds of procedures, whether you do a rigid annuloplasty ring or a De Vega type suture annuloplasty or some of these K annuloplasties that have been, they're completely ineffective for this disease. Why? For the simple reason that the leaflets are tethered. They're not coming together in the edge. There is no edge that's coming closer to each other. So how do we correct this? Well, I would argue to you that functional tricuspid regurgitation is exactly the same mechanism, not as dramatic as this, but it is the entire right ventricle dilating and pulling, because of this anterior papillary muscle, pulling this anterior leaflet outward, and so that it doesn't co-opt in the middle. So a ring annuloplasty for this is ineffective, and I think now the adult literature in functional tricuspid regurgitation is showing that simple annuloplasty ring may not be as effective either in the long term. And this is the evidence. I think this is also an adult study. Navia and his colleagues have shown that once you have more than 1 plus TR, the risk or the incidence of it increases over time. This is over a 5-year period, that once you have moderate or worse tricuspid regurgitation, the severity continues to progress. And this is in patients who already had something done for their tricuspid valve. Well, why is this concept so important? Why are we thinking about functional TR for congenital lesions? Well, again, I think there are important lessons here. And I think Robert already went over this, but I'll go over it again because I think it's a very important concept. When we talk about tethering height, what we're referring to is the height between the plane of the annulus and the point where the leaflets come together. So this is the tethering height. In an echocardiogram, it's the height between, this is the plane of the annulus, and this is the tethering height. So that is, the longer that is, the more likely that you're going to have tricuspid regurgitation. And then the other concept that's important is the sphericity index, and that is the distance between the apex and the base divided by the width of this is one measure. This is a Japanese group that described this sphericity index. And again, if this number is large, then the sphericity tends to go up, and the risk of recurrent tricuspid regurgitation also goes up. So we studied this concept of how do we address this tricuspid valve tethering and the spherical shape of the right ventricle. And we took this actually to the laboratory to study it. And what we realized is that what happens is not only is there eccentric annular dilatation, but also the free wall of the right ventricle dilates in functional TR, as well as many of our congenital heart defects. Well, the effect of that is to take this anterior papillary muscle, which supports the anterior leaflet and part of the inferior leaflet, and pulls it away from the septum. And that's what causes a regurgitation. There is an analogous concept for mitral, also due to papillary muscle displacement, but this is an ischemic mitral regurgitation, and it's the same idea. In systole, this papillary muscle gets pulled away, tethers this leaflet, and particularly the secondary cords, causing the regurgitant jet. In this lesion, this is that papillary muscle. It's not because it's ischemic, but it's because the loading conditions, the afterload on this right ventricle is much greater. So in systole, this papillary muscle, rather than moving towards the septum, actually moves away from the septum. So we do have many procedures that have attempted to either brace this part of the wall of the ventricle or pull that papillary muscle, the ischemic papillary muscle, towards the septum, preventing its tethering. The question is, could we come up with something like this for the right side? Could we come up with a way to take this anterior papillary muscle and keep it close to the septum, prevent this bulging, and in which direction is it ideal? And so that's something we took into the laboratory, and actually that's exactly what we did. Looked at it in a pig model initially, and now we've done clinical human studies. Took the head of this anterior papillary muscle and sutured it closer and closer to the septum. So actually brought it directly posterior to the septum, not to the annulus, because that will cause even worse regurgitation, but directly posterior at the same level. So what it does is it brings the anterior leaflet and septal leaflet edges together. And it's important to get that right, because when you do that, when you bring that papillary muscle over to the septum, then you get much better coaptation centrally. And this is in the echocardiogram and in our animal model study. What we found is this is the right ventricular free wall, this is the septum, this is that papillary muscle, this is the tricuspid valve. And as we brought closer and closer papillary muscle to the septum, we were able to, in fact, get rid of the regurgitation quite sequentially. And this was independent of whether you added a tricuspid annuloplasty ring or not. In white is without an annuloplasty ring. In black is with an annuloplasty ring. Adding the ring did not improve the regurgitation, but in fact the thing that improved the regurgitation was moving that papillary head to the septum. It's, again, not to the base of the leaflet, but directly posterior towards the septum. I'm going to jump now to a very different lesion, and then I'll come back to that concept and I'll show you our clinical results with papillary muscle relocation. And the reason for that is because that has relevance to this disease. And I think most of you will recognize this disease once you see some of the echo images. If they play, no? They're not playing. Try it again. No, I'm sorry, they're not playing. This is Epstein's anomaly of the tricuspid valve. So this is the left ventricle here. This entire structure here is the right ventricle. The septal leaflet now, instead of being up here at the annulus, the septal leaflet is here. This entire area is all atrialized portion of the right ventricle. On the lateral view, this structure here, which looks like a tiny appendage, actually is the left ventricle in this patient. This entire structure up here, that is their right ventricle. So this is a typical Epstein's anomaly of the tricuspid valve. The problem is not a deficiency of leaflets. There's tons of leaflet tissue. It's malposition of the leaflets. The leaflets are displaced, the septal leaflet in particular. There's usually a very large anterior leaflet, and often even a very large inferior leaflet, but they're malpositioned. And this procedure, which was described by Da Silva almost 8 years ago, and he has, I think, 13 years of follow-up, actually corrects that problem very directly. So in his procedure, which is called the cone operation, he actually detaches the anterior leaflet, the inferior leaflet, and the septal leaflet, mobilizes all three of them, sutures them side to side so that you actually create this cone shape to this valve. So you rotate the anterior and inferior leaflet, suture side to side the inferior to the septal leaflet that's also been mobilized, and then he does a simple suture annuloplasty. I've gone to ring annuloplasties in this patient in adults. In children, I still do this suture annuloplasty and resuspend this valve. If you don't have sufficient septal leaflet or you don't have enough tissue to rotate, you can put a triangular piece of pericardium here and it works just as well. In small children, we prefer to avoid the pericardium simply because it becomes stiffer over time, but certainly if you're doing this in older children or in adults, the pericardial augmentation of this component, this triangular area here, often is very, very helpful in achieving coaptation. So this operation, in fact, has really revolutionized the surgery for Epstein's anomaly in the sense that prior to this, only about a third of the patients could undergo effective repair. After this operation, almost all of the patients can now have effective repair. It's very rare for us to see a patient with Epstein's, independent of age, independent of how long that they have had the tricuspid regurgitation, for us to be able to do this procedure. The only thing that makes a difference is really how much right ventricle we have. So with this, our experience with tricuspid valve procedures has really increased over time. And at Boston Children's now we're doing a lot of tricuspid valve operations, almost all of them repairs. In blue is the repair. Replacement, extremely rare for us. And these are cases usually where repair has been attempted. The cone procedure, our experience also started at around 2007 when we first saw Jose Pedro do these operations in Sao Paulo, and we started to do them here, and now we're actually doing probably somewhere about a dozen a year to 15 a year of these cone operations in patients of all ages. What we found, however, is the problem with the cone operation is the fact that you do not respect any papillary muscle architecture. In fact, what you're doing is you're taking all of the attachments. I'm just going to go back here to this. You are detaching this valve. All of the attachments of the anterior leaflet to the free wall are taken down. What does that do to the right ventricle? It makes it even more spherical, because anything that's keeping that anterior wall of the right ventricle flat towards the septum has been divided. So as we gained experience with this papillary muscle approximation, treating other forms of tricuspid disease, including functional TR, what we started to do is save the anterior papillary muscle in the Epstein's patients and then suture that to the septum and add that to do the same mobilization of the leaflets, but spare that part of the valve, suture it to the septum, and then complete the cone operation. And in those cases, in fact, what we found is it's actually been pretty helpful. And this is a study that we published a few years ago, a couple of years ago now, looking at our experience over a 3-year time period with this right ventricle papillary muscle approximation. At that point, we had only 37 patients. Now we have over 120 patients where we've done this, compared to controls where we didn't do it. And this is for all lesions, including Epstein's, pulmonary atresia, intact septum, older TETs, even patients with single ventricle. This is hypoplastic left heart syndrome that we treat tricuspid regurgitation with papillary muscle approximation, and even AV canal defects. And what we found is that not only do we actually improve the tricuspid regurgitation, and this is without annuloplasty now, because it's all in small children, and in fact the durability of this is actually improved. But beyond durability, the important issue that we focused on was sphericity. And this is part of our clinical studies focusing on the Epsteins. What we found that in those patients, both in systole and diastole, if you look at the sphericity index, in those that had the papillary muscle approximation and those that did not, this is in blue is pre-op, in red is post-op. Those that had papillary muscle approximation had a substantial improvement in sphericity index as compared to those that had nothing done to the papillary muscle. And this was both in systole and diastole. We were able to improve the sphericity in those patients. We think that has long-term important consequences for preserving right ventricular function in these patients. So to summarize, our thinking and approach to tricuspid valve disease and congenital in many ways has been directed by not only the structural things we have to change, but also the functional aspects of these valves that we have to correct. The techniques that we have developed, which is this right ventricle papillary muscle approximation technique, I think we definitely are very enthusiastic about it in the pediatric world and have been using it both for functional TR in pediatrics as well as with associated lesions such as Epstein's. But I think it also has applications in the adult world, and I would love to convince my adult colleagues to at least think about the concept and see how they might apply it in your world. Thank you very much.
Thank you very much, Pedro, for this outstanding presentation. So it's open for discussion. Professor Dion?
Pedro, I would like to know how do you fix this anterior papillary muscle? You fix it under the septal annulus? You fix it to the head of another papillary muscle? How do you do that?
So it's the anterior papillary muscle, only the head.
Yes.
Never the body, because that will cut through. Just the head. and you suture it directly towards the septum. If there's a papillary there, you suture the two heads together.
I see.
If there's no papillary, simply put a large suture with a pledget on the septum and then approximate. You don't need to bring it all the way down to the septum. If you bring it 50% to the septum, it's enough.
So the head of the papillary muscle there against the septum eventually would do the case as well?
Yes.
Okay.
Yes.
And my second question is that in the Epstein, what are you doing about the arterialized part of the right ventricle? Are you plicating it systematically, and how are you doing that?
Yeah, I think that we are moving away from touching the atrialized portion of the right ventricle. I think the concept of plication made sense when there was very little done to reposition the tricuspid valve. When we reposition the tricuspid valve higher, then that part of the right ventricle either is akinetic or dyskinetic. If it is dyskinetic, then we resect it, just like we would for an aneurysm. If it is akinetic, I leave it. And the reason for that is when we went back and restudied those patients who had plications, they almost all had inducible ventricular tachycardia in that site. Because you're folding myocardium and leaving it folded for long term, and I think that's a substrate for ventricular tachycardia. Sudden death in these patients is not an uncommon finding. Something like 15% will have sudden death within 20 years after repair. So I have to think that plication is a contributor.
Pedro, having done some of these mitral valves and put a sling through the papillary muscles and the heads and brought those together, the obvious question, just thinking aloud here virtually, is have you done that in the large right ventricles where you've got a sort of big patulous ventricle and tried to do that, or even transfer the anterior leaflet?
You mean and transfer the anterior papillary?
Yeah.
Or yeah. The problem, I know what you're referring to, but you have two papillaries on the left ventricle that you can sling together. On the right ventricle, there isn't that. There's almost always a small inferior papillary, but it's too far away. That concept, I think, though, has merit. The question is, what can we use to bring that free wall back down towards the septum? I think the sling concept is good, but you have to somehow attach it to the septum.
Yeah, that's
and one of the thoughts, again, thinking just out loud, that I had was to take the same concept of the multiple cord loops that you use for chordal replacements, except suture it to the septum. Now you have multiple cords that you can pass through the free wall of the RV, and I think that will keep that RV free wall from distending, because I think that's where the morbidity comes from these patients.
Yeah.
Pedro, there is a subgroup of patients, especially in the older one, which have an ASD and Epstein. And in these patients, sometimes you experience a very severe right ventricular failure after you fix tricuspid valve. Do you sometimes use bidirectional cavo-pulmonary shunt in this?
Yes, I do, but very rarely. And the reason for that is because in most of those patients, the problem is that the atrialized portion of the right ventricle is very large. They have had very little in the way of pulmonary blood flow. They've been chronically quite cyanotic. And then suddenly you're increasing the amount of pulmonary blood flow by a large amount. You're shutting off that shunt. So it's a problem of right ventricular dysfunction. With this papillary muscle approximation, we've seen less of the right ventricular dysfunction. And so what we do right now is we will do our repair, standard repair, come off bypass, and then simply look at the right atrial pressure and look at the left atrial pressure. If I have a right atrial pressure that's twice higher, 2 times the left atrial pressure, then I'll consider a bidirectional Glenn. If I don't, I'll just wait. That right ventricle will recover.
Leo?
Yeah. A very short remark concerning atrialized part of Epstein anomaly. You know what? I do so-called vertical ventriculoplasty. I put my finger inside up to to the apex and make my 5-0 suture. And there was a doctor dissertation at our institution 3 or 4 years ago, and they showed that that procedure increased ejection fraction very, very significantly. Mm-hmm. because you really exclude, not like in Carpentier's procedure you do from inside, but you do outside between. So I think that it's reasonable anyhow.
What our resection technique is exactly that, except we resect rather than plicate. And the reason for that is just so that we don't have any ability for reentrant rhythms.
Yeah, but you know what? The reason I'm not cutting and suturing is that I was inserting also stem cells,
Okay.
autological stem cells into that area
Okay.
to be sure that it helps.
Okay.